When most people hear osteoporosis, they immediately think of postmenopausal women in their 50s. While it is true that the hormonal crash of menopause triggers the first wave of bone loss, there is a distinct, more aggressive phase that often begins after age 60. This phase is not driven solely by hormones, but by a convergence of lifestyle factors, medication side effects, and a critical physiological condition known as osteosarcopenia. This is the medical term for the hazardous duality of losing bone mass, osteoporosis, and muscle mass, sarcopenia, simultaneously. Research indicates that after age 60, these two conditions begin to feed off each other. As muscle weakens, it pulls less on the bone, signaling to the body that strong bones are no longer needed. This removal of mechanical stress causes your skeletal system to shed density rapidly. Essentially, your body starts downsizing its own structure to save energy. One of the most insidious drivers of this rapid loss in the over 60 demographic is commonly prescribed medication. Two specific classes of drugs, which millions of seniors take daily, are major culprits: proton pump inhibitors, PPIs, and selective serotonin reuptake inhibitors, SSRIs. PPIs used for acid reflux, like omeprazole, reduce stomach acid effectively, but your body requires that acid to break down and absorb calcium. Long-term use essentially starves your bones of their primary building block, regardless of how much milk you drink. SSRIs, used for anxiety and depression, have a more complex mechanism. Recent studies suggest that serotonin receptors on bone cells play a role in bone regeneration. These medications can disrupt the signaling between the brain and the bone, tilting the balance toward bone resorption, breakdown, rather than bone formation. If you have been on these medications for years, your bone density might be significantly lower than your age alone would predict. For men over 60, the risk is often entirely invisible because osteoporosis is clinically framed as a woman's disease. This statistical bias leads to dangerous underdiagnosis. While women lose bone rapidly during menopause, men lose it more gradually, but the mortality rate for men who suffer a hip fracture is actually higher than for women, nearly double in some studies. In men, the hidden driver is often a decline in available testosterone, which converts to estrogen to protect the bone, combined with lifestyle factors like alcohol consumption or corticosteroid use for conditions like asthma or arthritis. If you are a man over 60 and have noticed a loss of height or vague back pain, this is not just stiff joints. It could be microfractures in your vertebrae, a condition that affects nearly 1/5 of men with osteoporosis, often without a formal diagnosis until a catastrophic break occurs. Standard detection methods also have a blind spot for seniors. The gold standard test is the DEXA scan, which measures bone mineral density, BMD. However, BMD only tells you how thick the bone is, not how strong the internal structure is. You can have thick walls, but a rotting foundation. This is where the trabecular bone score, TBS, becomes vital. The TBS evaluates the microarchitecture of the bone, the spongy, honeycomb-like lattice inside. Many people over 60 have a normal DEXA score, but a poor TBS score, placing them at high risk for fracture despite a clean bill of health. If you are getting a bone scan, it is crucial to ask if the facility can calculate your trabecular bone score, as this software can often be applied to standard DEXA images to reveal the true quality of your bone mesh. Another silent sign that is frequently ignored is the condition of your teeth and gums. The jawbone is often one of the first bones to suffer from density loss. If you are over 60 and experiencing receding gums or loose teeth, this may not be a dental hygiene issue. It could be systemic bone loss manifesting in the alveolar bone that supports the teeth. Dentists are often the first professionals to see signs of osteoporosis, yet the connection is rarely made during a standard checkup. Additionally, grip strength is a validated biomarker for bone density. A weak hand grip often correlates with low bone mineral density in the spine and hips. If you find yourself struggling to open jars that you used to manage easily, this is a functional red flag for your skeletal health. To combat this, the generic advice of taking calcium is woefully incomplete and potentially dangerous if not managed correctly. Calcium needs chaperones to ensure it ends up in your bones and not calcifying your arteries. This requires adequate levels of vitamin D3 to absorb the calcium from the gut, and critically, vitamin K2 to direct that calcium into the bone matrix. Without K2, calcium can accumulate in soft tissues, contributing to heart disease. Furthermore, the diet must be protein-centric. The internal matrix of your bone is actually made of collagen protein. Seniors often undereat protein due to lower appetite. But to halt osteosarcopenia, you need roughly 1.2 to 1.5 grams of protein per kilogram of body weight. Without this protein structure, the minerals have nowhere to attach. Finally, the type of exercise required to reverse this trend is specific. Walking is good for the heart, but it provides almost zero stimulus for bone growth in the hips or spine because your body is too efficient at it. To stimulate bone growth, osteogenesis, you need osteogenic loading. This involves impact or heavy resistance. A simple, at-home technique is the heel drop. Stand on your toes and drop your heels down firmly onto the floor. The jolt sends a shockwave through the skeleton that signals the bones to reinforce themselves. Doing this 30 to 50 times a day, alongside resistance training that actually fatigues the muscle, is the only way to send the chemical signal required to override age-related bone loss. You must give your body a reason to keep its frame strong. Otherwise, biology will naturally dismantle it.